Good afternoon and welcome to Lynn Cancer Institute updates, keeping you in the know in 2024. We are very grateful to have all of you with us today to learn from our own physicians who will educate us on the newest information on skin cancer. At the Lynn Cancer Institute, we believe that education, prevention, screening, and early detection, a variety of treatment options, the expertise of our staff, and our latest technology will truly save lives. In the interest of time, the physician bios were sent to you by email. Your Zoom will be muted during this presentation, and we invite you to please take notes, and when you have a question, please write it in the Q&A chat box. The speakers will not be able to see you or hear you, so your questions must be written in the chat box in order for her to see the questions and respond. At the conclusion of the presentation, there will be time for your questions to be answered. Now, we are very proud to welcome you to the Lynn Cancer Institute and to introduce Dr. Ann Mazur-Reed, who board-certified dermatologist, medical director at Skin Care Research at the Rendon Center, Dr. Michael Casper, board-certified in radiation oncology and the medical director of radiation oncology at the Lynn Cancer Institute, and Dr. Lloyd Berkowitz, board-certified in medical oncology, internal medicine at the Lynn Cancer Institute. We will begin today with Dr. Reed. Thank you, Dr. Reed.
Thank you for that introduction, Brandy. I'm just going to share my screen here. Okay, so everyone can see my screen, right? All right, so hi everyone, I'm Dr. Ann Mazur-Reed. May is Melanoma Awareness Month and Skin Cancer Awareness Month, so it's a wonderful timing to have a discussion about skin cancer and skin cancer prevention, and thank you for having me today. So there are many types of skin cancers, basal cell, squamous cell, melanoma, those are the most common type that we see, but there are other types of skin cancer. And down here, this is Jimmy Buffett that has brought a lot of attention towards Merkel cell carcinoma, which is a rare type of skin cancer. But I do appreciate that I have seen more patients come in for skin cancer screenings because people are more aware of it now. Unfortunately, he did pass from Merkel cell carcinoma. So there are many types of skin cancers. We're going to talk about the most common types. So basal cell carcinoma is the most common type of skin cancer, usually develops after sun exposure, or if a patient has a history of indoor tanning, typically sun-exposed areas. So it'll be head, neck, arms, legs, but can be found anywhere. Often looks like a shiny, pearly, pink-colored bump, and there's some examples of the nodular basal cells here. And some superficial types can actually just look like a pink patch of skin that you'll see here on the bottom right. These are extremely curable. The cure rate, we just remove them. And if they are allowed to grow, they can cause disfigurement. And there are many types of options to treat these, which we will get into a little bit. I just wanted to show different examples and how different basal cell can look on the skin. So this is a patient with longstanding stasis dermatitis, and he always had his feet in the sun, never really put sunscreen on them. This is a large basal cell on the foot, a few on the arm here. This is a superficial one. This is just a zoomed in dermoscopic photo of a superficial basal cell on the back of this patient. The next type of skin cancer is squamous cell that we're going to discuss, the second most common type of skin cancer, again, typically found in sun-exposed areas, although we can sometimes get squamous cell in areas of trauma, areas of burns, recurrent wounds can sometimes develop squamous cells. So it's not always sun exposed. It can look like a red, firm bump, a scaly patch, or a sore that's constantly healing and reopening and healing. They can grow deep into the skin. They can metastasize. They can cause damage and disfigurement. So really early diagnosis and treatment of these lesions are essential. And, we can have advanced squamous cells So these are things that need to be diagnosed and treated early. A few examples of some squamous cells. This is just a photo of me excising a very small one on the back of this patient. This little bump on the arm, on the hand here, is another squamous cell. Melanoma is the deadliest form of skin cancer because it has a tendency to spread and metastasize. It typically appears as a dark spot that looks different than the rest. We can, sometimes we call it the ugly duckling sign. So let's say a patient comes in, they're covered in moles, but there's one that kind of stands out to you. You don't need a medical degree to see that something stands out. We kind of learned it on Sesame Street, like one of these don't belong and the rest do. So look out for that mole that it looks different than the rest, because again, early diagnosis and treatment are crucial. And I'm going to review what we call the ABCDEs of melanoma. So these are some examples of melanoma that I found in my office. If you look at this patient's back, I would say that this stands out. So this is definitely something that should hopefully prompt you to come in to the office and have it looked at. This is what it looks like under dermoscopy on the bottom left. So we're seeing something that is not symmetric. It's got an irregular border. Those little tick marks on the left side are millimeters. So that's 3, 4, 5, 6, 7, 8. So 9 millimeters right there. So that would be prompt me to biopsy or sample something on the skin. This lesion here honestly looks like a sunspot. It looks like a freckle under dermoscopy. Nothing really. We do have like a reverse pigment network and certain things that a trained eye can see. And then on the bottom right, this patient has had that as his birthmark since he was born. So, we can have things that we've had our whole lives that do change and prompt you to have it checked. This lesion in the center here is an example of an amelanotic melanoma. This is a pink ulcerated lesion on this patient's back that initially was thought to be a basal cell just based on how it looks. So we did need sampling of this to get a diagnosis. And then nail melanoma, while it is rare, can absolutely happen if you have any pigmentation on your nails that's larger than about 3 millimeters in width. Definitely come have it checked out. And then obviously ocular melanoma is something that can occur as well. I just briefly Merkel cell carcinoma, just because so many people ask about it and everyone knows because of Jimmy Buffett. This is a rare aggressive skin cancer that grows on the outer layer of skin, very high risk of spreading and recurring. 80% of them are caused by a virus called Merkel cell polyomavirus. 20% are caused by UV radiation. We rarely find these at an early stage. They honestly look like a red bump on the head and neck. And immunotherapy, I know I'm not a oncologist, but I would just want to mention how wonderful immunotherapy has advanced and how we are now able to treat these advanced skin cancers such as melanoma and Merkel cell. And hopefully in the future, people don't, it doesn't have to be a deadly illness or a deadly skin cancer. So let's quickly review the ABCDEs. Asymmetry is A. So you're just basically having two sides that don't match. If the borders are even versus uneven borders are going to be a sign of atypia. More than one color, so 2 or more colors. And you can see here a nice example of a benign lesions on the left and malignant melanoma on the right. 6 millimeters is sort of our cutoff. If everyone knows what a pencil eraser size looks like, that is our cutoff. So if it's larger than that, that would lead us to look deeper into a lesion. We have E for evolution. So this means something's changing. The patient comes in or you tell your doctor, it used to look like this and now it's changing. Definitely something that you'd want to come in and get a skin check for. So this is how we screen and diagnose. So we look with our dermatoscope, which is what you see me holding here on the left. We do biopsy them. We have reflectance confocal microscopy. We don't have it in our office, but there are some offices that will do that. Melanoma specialists will typically do confocal in order to see deeper into the skin prior to biopsying. And then we do have a wonderful ability to test genomically. There is a DermTech melanoma test that's like a patch test or a sticker test that gives us the ability to know gene expression and whether or not genes are being expressed in a mole. And then there's Castle testing or DecisionDx that is a wonderful way to help guide us in terms of diagnosing and how we're managing these lesions. This is just for information, what a shave biopsy looks like, what a punch biopsy, and an excisional, which is typically what we'll do for melanomas. Excisional biopsies. So prevention is key. Just really quickly, just reviewing how we can prevent, mainly caused by sun exposure, to be honest. And, we want to avoid peak sun hours. Don't bake in the sun, just seek shade, apply a broad spectrum sunscreen. Our kids are protected by parents, by us, by adults who really need to make sure that their kids are not getting sun exposure or too much sun exposure. Those UPF clothing is wonderful, especially in the summer. This is my son here with a hat and a long sleeve shirt. He's got sunscreen on his legs. And it's our job as parents to protect our kids. This is just a really, I think it's a wonderful photo from the New England Journal of Medicine. This was a truck driver who for many, many, many years drove a truck on the left-hand side. He was getting a lot of sun exposure, and you can see not only, does it cause skin cancers, as we know, but it ages the skin, and people, we don't want to look older than we actually are. And so protecting yourself from the sun can decrease aging of the skin. And then really quickly, I have a nutritionist background, and I think that it's really important to feed our bodies in a way that will help us prevent, not prevent, but, give us the best chance we have to avoid cancers and avoid inflammation in the body. Nicotinamide is a vitamin B3. There was a large study that was done that showed that 500 milligrams of nicotinamide twice a day can reduce risk of precancer and squamous cell carcinoma by almost 25%, which is huge. That's a really nice thing that you can take. It's a water-soluble vitamin. Obviously, speak with your doctor first. You can also get it in chicken, fish, eggs, and nuts. And then briefly on polyphenols, very important to eat fruits and vegetables that are an orange hue or red in color. You can see as an example, sorry about that. As an example, I have pomegranates, carrots, watermelon, grapes, strawberries, tomatoes. All these things have polyphenols in them, even dark chocolate. So people who are into chocolate, dark chocolate can provide you with a little bit of antioxidants. It can give us a natural defense that can help with while preventing these types of cancers and precancers. And then lastly is this fern plant called Polypodium leucodermis. This was discovered that has the ability to actually protect our skin from the sun and decrease our erythematous dose, basically what it takes for us to burn. So let's say it takes us 10 minutes to burn in the sun. If we take this, perhaps it'll be a little bit longer that we can be in the sun with protection. So I'm not sponsored by anyone or anything. There is a brand called HelioCare that does have nicotinamide in it and Polypodium leucodermis, and that's an easy way to get that type of antioxidant in your system. So that's time for me. Thank you so much for listening, and thank you for having me back.
Thank you, Dr. Reed. I love the nutrition information. That was awesome. And now we're going to segue to Dr. Casper.
Good afternoon. Thank you for joining us. Do you see my screen? All right, I think we're good. So thank you for joining us. I want to say a couple of words as introduction regarding radiotherapy. Many people don't know much about radiation, and a little bit about our program. And then I'm going to discuss some of the results, show you a few pictures and treatment options for skin cancer using radiation. So first, I want to say a word or two about radiotherapy. Although radiation is the single most utilized agent in oncology, it's frequently not very well understood by patients and even many physicians. For this reason, it's sometimes underutilized, despite being a very high value and efficacious treatment for cancer. 50 to 60% of all cancer patients receive radiation, and 40% of all cancer cures are primarily due to radiation. For that reason, I think that it's very efficacious compared to some of the costs of other treatments, and it's still sometimes underutilized or underappreciated. It's also important to note that where you receive your radiation can make a big difference. Small changes in radiation delivery, for instance, in dose and technique and field size, expertise, quality assurance protocols, which we do quite a bit of here. These things can have a really large clinical impact. And I guess you can say that in all areas of medicine, but I think it's particularly true for radiation and especially skin cancer and radiation. And one of the many features that sets the Lynn Cancer Center apart is our multimodality clinics, in which we have site-specific cancer surgeons, medical oncologists, radiation oncologists, as well as radiologists, pathologists, psychosocial experts, and dietitians, who all meet the patient at the same visit, and then they get together and discuss the patient's case. And this coordinated process really facilitates communication and it expedites further testing for the patient. It's a collaborative treatment, and collaborative treatment decisions that are made, and the quality of those decisions are usually far superior to what is the standard in the community. So I can't speak highly enough for the multimodality process that we do have here at the Lynn Cancer Institute. Now I'd like to just share with you a few of our patients who have been treated with radiotherapy. And these are typical cases. These are patients we see every day. I've got several patients who have lesions. In fact, I have one exactly like this in the eye, a little bit bigger, and a few others that are similar to the other patients. So this is a woman who had a basal cell carcinoma of the right medial canthus. This is very close to the eye. She was 100 years old, so they said, well, do we really need to do something? But it was really starting to bother her. And we were able to treat this because it was near the eye. We took it a little bit more slowly than we frequently do and treated over about 4.5 weeks. But you can see she had a beautiful outcome. Everything healed nicely. There's no evidence of the cancer. And she was very, very pleased and did well. And this is just a couple of months out after treatment. Here's another lady with a neglected lesion of the lower lip. This was a squamous cell cancer. She was treated in just three weeks, and you can see a beautiful outcome a couple of months later. It's completely healed, and she was very happy. Lips are tough. Lips are very, very sensitive, and they can be painful, but even lesions like this are very painful on the lip. So, the treatment is not too long, and patients heal nicely, and then they usually do very well afterwards. Here's another woman with a lesion on the lateral, just lateral to the eye on the temple. This was treated over again 3 weeks, and this was 6 weeks after treatment. You see, we still see a little bit of a scab there, but this healed as well. That scab fell off, and she was completely healed and cured of her cancer. Another patient with the squamous cell of the left ear. You can see this large lesion here. He had come back for another reason 5 months later, and you can see that is gone. And this patient was actually a palliative patient. He was, dying from other issues and had this big cancer that was very difficult to take care of. It was bleeding and smelling, and they just couldn't wrap it to keep the oozing in check. So we were asked to palliate it, and it was treated over 1 week in just 3 fractions. So, and this was treated with one of our linear accelerators, and you can see it was very effective at getting rid of that. This was right after treatment. So I don't know how this patient healed. Usually something like this will take quite a while to heal, but it can heal up. It won't heal if there's a cancer there, but once we get rid of the cancer, usually they do heal after radiation. This was effective. It was easier to take care of now and clean and cover, and they were very happy with this. Now, I show you all of these to demonstrate that skin cancers are very sensitive to radiation, and patients usually heal very nicely afterwards. So radiotherapy works. So it's a relatively good option in difficult to treat areas, larger cancers, recurrent tumors, areas where it's going to be tougher to reconstruct with plastic surgery after Mohs surgery. Mohs is still the gold standard, and certainly on flat surfaces like arms and back and chest, certainly surgery is the way to go. But on tougher areas like the nose, the ears, the lips, radiation is a good alternative. I wanted to say a word about some of our tools. We have multiple tools here as a comprehensive cancer center to treat and cure skin cancer. These include some of the various machines that create different types of radiation depending on the location, the severity, the depth of invasion of the skin cancer. Superficial X-rays are really marketed quite a bit these days. Superficial X-rays have been around for 75 years, but they put them now in very boutique-y-like packages, and they've been moved into dermatology offices and a lot of other type offices, and it's been touted as the best treatment for skin cancers. And actually, it is quite good for superficial skin cancers, but it's not one size fits all. We have electrons and high dose rate brachytherapy that we do use that mimic the superficial X-ray, so we get the same dose coverage as you would with superficial. But we also have many other types of treatment that fill other roles for perineural invasion or deep extension or metastatic disease. So here are some of the other machines that we have. This is some of the technology that we have. We have all of these machines at our disposal. For instance, we might use the CyberKnife that you see here, or the MR-Linac for metastatic disease to the lung or the brain from a melanoma. The Proteus One here, this is the new proton machine that we're putting in the front of our building. That's not available yet, but we probably would not use that for most skin cancers. Although I could see in the future for perineural invasion in head and neck skin cancers where it's going back toward the brain, where we will be using protons in those situations. But for standard run-of-the-mill skin cancers, we wouldn't do that. This is the this is our Flexitron. This hooks up to our high dose rate brachytherapy machines that does some of the other types of treatment that I'll show you now. This is a Freiberg flap where we make a mold. The mold immobilizes the area, and then we have these catheters that are attached to the treated area, and then these tubes are transport tubes for radioactive sources that come in and very precisely give a nice even dose over the area to be treated. This is a very sophisticated treatment of a finger. Fingers are very difficult to treat because we can't give radiation to the entire finger. You can cut them off and surgery is good, but if it's a large lesion and surgery is no longer an option, you have to be very careful with radiation. And this is one way that we frequently do it and have a lot of success. Here's another type of high dose rate brachytherapy. We have these small applicators, and these are in sizes from 1, 2, and 3 cm. And we place these right on the tumor and deliver a very quick, very precise, effective dose of radiation. And we do these treatments in 6 to 8 treatments. So it's very quick and effective. And we also have another type of radiation. We're participating in a trial for difficult to treat lesions with a new type of alpha radiation. And in this case, we do interstitial implants where we insert the radioactive needles right into the tumor. So we have a full complement of tools to treat skin cancers because we're a comprehensive cancer center. So we We have a lot of experience in it and work closely with our dermatologists and plastic surgeons and see our patients in our multimodality clinics, and happy to help you if you need help. So last year, I started off the talk with a few slides about Madame Curie and talked about her Nobel Peace Prizes and how unique she was as one of the foremost scientists in the history of the world. She discovered radium and first treated skin cancer over 100 years ago. So I couldn't resist when I found this romantic old photo of her and her physicist husband, Pierre. So I thought I'd share that with you. Thank you.
Thank you, Dr. Casper. That was great. So interesting and informative. And now I'd like to introduce Dr. Berkowitz.
There we go. Everybody can see that?
Yes,
Excellent.
we can see it, Doctor.
All right. Very good. So I'm going to give an update on systemic treatments for cutaneous malignancies. I deal primarily with chemotherapies and immunotherapies for various skin cancers. Just wanted to define our terms a little bit. We use systemic therapies for a variety of reasons. The most common reason in the past has been patients who don't have a curative option with either surgery or radiation therapy, and that's treating metastatic or locally advanced disease. Those patients are not initially treatable with surgery or radiation. We do a lot of therapy, what we call adjuvant therapy. These are treatments given after the primary tumor has been removed to reduce the recurrence rate. This is very common in a lot of malignancies, and since the advent of new chemotherapies for diseases like melanoma and immunotherapies, adjuvant therapy for these diseases become very common. The other term I want to define is called neoadjuvant. Neoadjuvant therapy are therapies given prior to surgery or radiation therapy, either chemotherapy or immunotherapy, to try and improve the chances for complete eradication of the tumor. And I'll show you some examples of that in a sec. So when we treat locally advanced and metastatic cancers, what are we talking about? Well, if I had been giving this lecture 20 years ago, I would have only the first line to talk about, which was the use of interferon and interleukin, which were really sort of the earliest immunotherapies that were used systemically. But now, fortunately, we have a variety of new agents which are incredibly effective. The most common thing you hear about is immunotherapy, drugs like Yervoy, Opdivo, and Keytruda. Probably see a lot of commercials for Keytruda. In fact, melanoma was one of the first diseases that had approvals for these immunotherapies, and there have been many malignancies that have followed suit. As far as chemotherapy is concerned, the more traditional type of treatment for malignancies, in the old days, we used to use a drug called dacarbazine or its oral relative temozolomide. Unfortunately, the response rates are very small, 10 to 20%. Nowadays, when we analyze patients with melanoma and we send their tumor tissue for mutation analysis, those patients that have what we call a BRAF mutation, and that's about 25–30% of all melanoma patients, we now have a very effective oral chemotherapies called the BRAF-MEK combinations. There are actually chemotherapies for basal cell cancers, what we call the hedgehog inhibitors. Eravage is the most commonly used one. Those are not appropriate for basal cell cancers that could be treated either surgically or with radiation therapy. But occasionally we'll see patients who have had either neglected basal cells or spread to local areas, and those patients cannot be treated with surgery or radiation therapy. In fact, Dr. Casper and I were talking yesterday at our conference about a patient that we saw in our multimodality clinic who had a long neglected basal cell carcinoma, is coming close to her eye, similar to the picture that Dr. Casper showed. We placed her on Eravage. I just saw her recently. She's had almost total disappearance of this very advanced basal cell that she had on her face. I tried to get her back to see Dr. Casper, but she's a little freaked out about the concept of radiation. So right now she's staying on Aerovage and seems to be tolerating it well. Dr. Reed mentioned Merkel cell cancers in the past. We had the only way to treat patients who had advanced Merkel cell was with chemotherapy. But now we have two very active immunotherapy drugs, avulimab and Keytruda, which is pembrolizumab, and they are excellent treatments for Merkel cell cancers. So I want to talk about adjuvant therapy for melanoma for a bit. The adjuvant therapy, again, are treatments used in patients who have had removal of their tumor, but have a high risk of relapse. In the past, the only treatment we had that was appropriate was what we call high-dose interferon, which if you have ever had the joy of being on interferon for a year or spoken to any oncologist who had to prescribe it for a year, it's really difficult treatment. It's basically putting patients through a lot of side effects for an entire year. And now that the studies have been mature, the actual ultimate reduction of recurrence rates was quite small. So fortunately, we're not using interferon anymore as an adjuvant therapy. The two drugs that have been approved on the immunotherapy side are Opdivo and Keytruda, quite safe, much better tolerated than high-dose interferon, and gives much longer prolongation of remissions. The BRAF-MET combinations can also be used in patients who have to have the BRAF mutations. My bias is to use the immunotherapy drugs, Opdivo and Keytruda, rather than the BRAF-MET drugs. I think they work better and have much less toxicity. So again, adjuvant therapy for melanoma is used for patients who have lymph node disease at the time of their surgery, but also useful in those patients who have metastatic melanoma, often to one spot where those areas can be removed. And once the site of metastatic disease is removed, what we call no evidence of disease or NED, those patients are at high risk for relapse. So we know that immunotherapy can be of benefit in those patients. There's also recent data showing that immunotherapy can be benefit in patients with negative lymph nodes but have a large primary melanoma. So those patients also can be treated with immunotherapy. I just want to say, just review quickly, one of the neoadjuvant therapy studies is from the Southwest Oncology Group. Again, neoadjuvant therapy is the use of medication before either surgery or radiation therapy to improve the chances. So what they did is they took 300 patients with melanoma and they randomized them into two treatment arms. Group A was the typical treatment, which was surgery followed by postoperative immunotherapy with Keytruda. The second arm was 3 cycles of Keytruda, which is basically 9 weeks, one treatment every 3 weeks, followed by surgery, and then followed up with Keytruda afterwards. And after 2 years of follow-up, the metastasis-free survival in the first group was about 50%, but improved to almost 3/4 of the patients in Group B. So there was a significant improvement by using Keytruda preoperatively in those patients who have high-risk melanoma. Just want to go over this case study to show how far we've come in treating metastatic melanoma. This is a patient who I've seen over the last couple of years who moved here from Kentucky in 2015. He had a moderately large melanoma on his chest wall, 2.4 millimeters. Postoperatively, he was treated with a clinical trial with dacarbazine, which is an old chemotherapy drug, interleukin-2. Despite this post-op therapy, he developed metastatic melanoma to his lungs and liver and was started on Keytruda. He's been free of disease ever since. It's now 2024. His recent PET scans totally normal. He's tolerated therapy incredibly well. The only side effect has been vitiligo, which is a depigmentation in the skin, which sometimes can be unsightly, but certainly is not painful in any way. So this patient has had a great response to therapy. So some may say, well, you're picking out the best patient here to show off. I said, well, that may be true, but there was another slide I wanted to add on, but I couldn't figure out how to do it, but I'll describe it to you. It showed survival curves pre-immunotherapy and BRAF therapy compared to what we're seeing now. So prior to the development of these new immunotherapy and chemotherapy drugs, the average survival with dacarbazine, which was the old chemotherapy, was approximately 6 months. And there was no, if not to go through medical statistics at all, but when we look at survival curves, what we look to see is if there's a tail at the end of the curve, which means that the curve no longer is decreasing, which may mean that those patients may be cured. So for the dacarbazine patients, there was a drop off each year that you followed patients, and the average survival was about 6 months. Now, with the advent of immunotherapy, survivals are far longer than that. The average survival on the initial trial looking at Yervoy and Optivo is now the average survival is about 6 years. And there are some patients out 10 to 12 years with no recurrent disease. And my assumption would be that those patients out that long are probably cured of their disease. So we're not perfect yet, but we've certainly made major strides in the treatment of melanoma and other skin malignancies over the last 15 to 20 years. Thank you for your attention.
Thank you so much, Dr. Berkowitz. That was very interesting. We do have one question in the chat, in the Q&A, and Dr. Reed, I think, already answered it, but I'm going to go ahead and just repeat it, and if you want to answer it again, Dr. Reed. Though less common, what do skin cancers look like on people of darker hues?
That's a really important question. Although it is more rare, we absolutely can get skin cancers in any skin tone. Typically, in darker skin tones, you're going to see more commonly acral melanomas. So that's going to be on the hands and feet. Any dark spot that looks suspicious should absolutely be checked. Darker skin tones can still get sunburn. They can still get skin cancers. Instead of things looking a little pink or red, you're going to see more of a violaceous hue, like a purplish color. But we can recognize them in any skin tone. So at least once a year, we should be coming in to get your skin checks.
Okay, great. Thank you so much. And let's see, I have one more here in the chat. Nope, just a lot of thank yous. Very good. All right, so if we don't have any more questions, we will go ahead and end our presentation. Thank you so much, doctors. We all learned so much from you today, and we're so grateful. All of our lectures are recorded, so this presentation, as well as all of our past and the series, are posted on the website. So you can watch today's presentation again or share it with your friends and family if you like. Lee will send the link in her follow-up email. You will also receive an evaluation sheet. These evaluations allow us to add your name and email address for future mailings, as well as to address any suggestions that you may have in the future. We appreciate everyone who has joined us today, and we hope to see you for our next presentation on Wednesday, May 22nd at 11:30 for our presentation on culinary pharmacy with Marie Morandi. Thank you, doctors and everyone, and have a great afternoon and weekend.
Thank you.
Bye, everyone. Thank you.
Bye.